Hi everybody. We've started this Facebook Live a little bit early tonight because last time people missed out on the beginning. So we're not going to officially start talking about the CSA probably for a minute or so. So if you can just bear with us, just also if you've got any questions that you've got in mind, do start posting them up because we'll be taking this Facebook Live a little bit early tonight. We'll be taking those towards the end. Anyway, I hope you've had a good couple of days. Certainly, yesterday was a bit of experience down here. We sort of had the most bizarre weather. It was like some sort of sandstorm sort of flew past. And I know that certainly up north people have struggled a wee bit. So I hope that everybody's okay.
Got 3 people joining us now, 6.
So welcome if you've just joined us. A number of people have just joined. We are going to get started as soon to 7 o'clock as we can. I just didn't want to start without some of the groups that wanted to join this evening. I know that some of you are probably just coming back from work actually, so it is only just 7 o'clock. Well, we were delighted actually when we got back from work this evening to set up because next door they've decided, next door to my house, they've decided to put some scaffolding, which sounded like they were actually trying to knock down my house. Unfortunately, they've stopped in the last few minutes, so that was a bit of a relief.
Just give me 1 more minute.
I'm not sure the builders would have understood if I'd have gone out and said, shut up, we're doing a CSA live. But anyway, it might have been worth a try. I could have done it with a black eye.
Okay, should we go?
Okay, so we're going to get started. I hope most of you will know that my name is Mark Coombe. Welcome to this 14 Fish Facebook Live. I'm a current CSA examiner. I've been with the CSA since it opened up, and in fact I was one of the original management team of the CSA and managed with our small band of other examiners the CSA for the first 6 years. I'm also the inventor of the 14 Fish Pass the AKT and Pass the CSA packages. Because of my involvement in courses and with helping candidates that were struggling, I've helped thousands of candidates through the CSA. So I hope what I've got to say tonight is going to be useful. And what I really want to talk about is the consultation and consulting in the exam. If you're sitting the exam in the next few weeks, this is all probably a bit, you've done this a long way before, so I apologize if it's a bit basic, but if you are sitting, you've just joined ST3 and you're sitting the exam over the year, then hopefully that you will find it helpful and it will maximize your score. So just to go back to the beginning, really, the problem that we have is that the vast majority of your training in medicine is in hospital medicine. So when you arrive in general practice, you've spent at least 10 years, and some of you will have done speciality training. One of my partners is an orthopedic surgeon, and so he'd been in hospital medicine for at least 10 years. So you come out of hospital medicine with very much a disease-focused way of managing patients, and so you've been taught for years this model, and you really struggle when you get into general practice to get rid of it. But you really do have to get rid of this disease-focused model, because in primary care we don't have people presenting with diseases, we have people presenting with symptoms, and the disease-based model is really good for somebody who's already been screened by a number of medical people or already had investigations, whereas you as GP are seeing patients for the first time, and so they're just presenting with a symptom, and symptoms certainly don't mean disease. If you look at some of the work that's been done on presentation of symptomatology in general practice, then 95% of people have experienced at least one symptom in the past 2 weeks. And certainly, you know, I'm sure some or all of you have woken up in the last few days not feeling 100%, and perhaps if you weren't medical, you might have sought medical advice. And most people can recall having symptoms in the relatively recently. So we've got to move away from the disease. Hospital doctors like doing lots of investigations and tracking down the disease, and they tend to sort of cross-refer and spend lots of money looking at people, but thinking them of as a disease as opposed to a person with a symptom. So your approach in general practice, you sort of have to delete all of your communication skills with patients that you've done in hospital medicine and start again. And so don't be scared of losing all that behind. That's really important. The reason why you're worried is in hospital medicine, there's a lot of people who are ill. So 95% of patients who present to the NHS are managed in general practice, and only 5% of them go to hospital. So when I first started in general practice, I assumed that everybody who came in through my consulting room door had cancer or something significant. And so you need to look at the numbers of people in your practice who present with significant disease and just start to realize that probably if you have 2,000 patients and you consult 8 to 10 sessions a week, then you're going to only see 8 new cases of cancer. And so that old expression, the best thing about being a GP is you never know what's coming through the door, and the worst thing about being a GP is you never know what's coming through the door. But if you're continually scared that whatever's coming next is going to be a serious disease, then you're going to run into trouble and it's going to become very stressful. So you need to have your clinical skills about you, but you need to think to yourself, tell me more about your symptoms, and this isn't necessarily a disease, and almost certainly it isn't a disease. So being a GP is being about an expert in the consultation. So disease-based medicine is all very well for these hospital doctors, and they, with all their clever tests and machines that go beep, we're very much on our own, aren't we? And so you've got to find a way of conducting yourself through the 10-minute consultation, so that you start at the beginning and you get to the end, and over that journey in 10 minutes, then you've actually achieved a series of tasks. But thinking a bit more clearly about some of the models, when you first get into GP training, everyone talks you about consultation models, and there's actually loads, isn't there? Sort of Stotton Davis and Roger Neighbor and Byrne and Long, and 6 phases, and transactional analysis and all that sort of guff, and you think to yourself, this is not going to help me at all, and it's not really very practical. So hopefully what I'm going to say in the next few minutes is going to be a much more practical way of looking at the consultation. So although symptoms are important, almost as important is the patient's perception of those symptoms, or of that set of symptoms that they present with. And how patients deal with their symptoms is called illness behavior. And it's affected and influenced by a number of different things. And you can probably think about them. So if you think about the last few patients that you've seen in general practice, one of the commonest reasons that patients present is because they've gone on the internet and they've Googled it, haven't they? So they've typed in headache into Google and it says, the commonest cause is brain tumor. Other influences it depends on your family, doesn't it? Not just your family. There's probably someone in your family that you go to for advice. There's probably a friend or somebody in the community that you go to. Some people have an expert in their family, or I work in a small village in the south of England, and there seems to be an expert in our local pub, and quite frankly, if I get the opportunity, I'll go around and strangle him, because his advice is generally appalling. Anyway, so you've got this series of influences that alter illness behavior. Other things that alter illness behavior are people's previous experiences. Social triggers, for example, pressures from others. Let's say, for example, your boss says, if you keep turning up late for work, then I'm going to sack you. Then you might go and see the doctor. your personality. So people's personalities, so your ability, how robust are you? How able are you to deal with a symptom? How willing are you? You know, what sort of type of person are you? Are you willing to just let it happen? Are you willing to wait and see? Or are you somebody that needs to know immediately what the problem is? And other things in your life, your levels of stress. So what I'm saying to you is that when someone comes in to see the doctor, they haven't just come in with either a disease or with just a set of symptoms. What they've come in is with a whole sort of, it's like a bubble. So you've got the person with their symptom, and then there's this bubble. And this bubble contains a whole load of things. And, you know, you'll hear it over and over again. It contains their ideas, concerns, and expectations. But these have been manipulated and changed by a lot of people. And you've got to find out what's in that bubble. Otherwise, you're never going to get to the end of the consultation. Or if you do, you're certainly not going to be with the patient. So when the patient comes in, they've got this specific idea of what you're going to do, what you're going to be like, sort of things that you're going to say. And you've got to get to the end of the consultation and make sure that you've uncovered all of that. And if you don't, you get what's called a dysfunctional consultation. And I certainly had one or two this morning. I came to the end and actually it might have been easier if we were both speaking in a completely different language. And it's not very satisfying, is it? You have a dysfunctional consultation and you get to the end of it and that's rubbish. I often hear my new registrars say, oh, I had a really good day today. I found a couple of people with, you know, appendicitis, or, you know, someone had a disease. You know, you've got to, as a GP, that's very secondary. That's very simple. When somebody comes in and they look like death's door, you know, they're really ill, they've got a tachycardia and high temperature, it doesn't really matter what their diagnosis is because they're probably going to go to hospital. And so you need to get more into the whole presentation and the illness behavior. So how are you going to do this in 10 minutes? Because 10 minutes isn't very long, is it? In hospital medicine, you do a history and examination investigation. You get about an hour, don't you? And you've got 10 minutes. And you're the first person to see it. And your best opportunity to get to the bottom of why a patient is consulting is in that first 10 minutes. Because once you put a diagnosis on your screen, once you've coded that there's something wrong with them, all the other doctors that see them do exactly the same. Oh, I saw you had irritable bowel last year. Oh, you came in and saw somebody with a, you know, tension headache. And we tend to then follow what people have said. So it's really important. And in the CSA, you're going to be seeing people for the first time. So it's that sort of magic first 10 minutes of you with the doctor. But you've really got to alter, so dropping that disease-based model and think about their illness behavior. So you need to learn a completely different way of doing it. And the way that I teach and the way that we teach on the 14 Fish past the CSA package is to divide the consultation into 3 sections. And you've got to look on those sections as individual items by themselves. So you do section 1 and you complete it, and then you do section 2 and you complete it, and then you do section 3 and you complete it. And you only go back if something comes out that you weren't expecting. So you start at the beginning, get to the middle, and then get to the end. But what you don't do is you don't keep going backwards and forwards. When I first see my registrars, and when you see a failing candidate in the CSA, they often do go round and round in a circle. They often ask the same bits of the history over and over again, or they go back to seek confirm understanding, or they're summarizing all the time. And actually that doesn't help. So think about your sections, beginning, middle, and end, and ask a section in a go and keep moving on. And that way you'll get to the end. The commonest cause of failure of the CSA in the UK at the moment for both UK and non-UK graduates is failing in clinical management, which is the end of the consultation. And a lot of people are failing in that. One, because they're not keeping up with their clinical skills and not keeping up with their clinical knowledge and their current guidance, but 2, because they just don't get there. So what's in our first section? So section 1 is your greeting. So you're welcoming somebody in the CSA. My advice to you would be to sit in your desk, sit in the chair. When the buzzer goes or the bell goes, the door will open, and then I would stand up and greet the person in the way that you would normally greet them. I tend to shake people's hands, but that may not be your cup of tea. So I would greet them in the beginning. How can I help today? Some people say, what brought you in today? And that old chestnut of an ambulance doctor is never going to help, is it? So how can I help you today? And then I would personally let them deliver their opening line. So in the CSA, they will have an opening line. let them deliver the opening line, and then I would say, I haven't met you before, can you just give me some background? And why I'm wanting background is to try and discover about their illness behavior. What are their influences? What's altered the perception of their symptom? So I would tend to say, who's at home with you and how's that affecting you? How does it impact on your day-to-day life? What is it that's brought you? Why did you decide to come in today? You know, you've had a headache for 6 months. What is that particularly triggered your illness behavior to change? Because quite often that's very relevant, and it's quite often relevant at the end of the consultation because you can use it in your explanation. So once you've talked about and you can summarize, you can give a brief paragraph of who they are and how this illness is impacting and why they've come into you today. I want also to then get to the bottom of their theories. So what were their ideas? Some of my registrars, when they first start, tend to sort of say, you know, did you have any thoughts? And they look fairly unconvinced, and the patient then thinks, is this guy medically qualified? And what you're really wanting to do is saying, now people come in with a theory. It's really common. Lots of people look it up on Google. Lots of people speak to their family. So what was your theory? Because it's important. And so what was your theory? And once you found that out, you can find out what they thought they were going to get. And it's bizarre. People have really bizarre thoughts. You've been in medicine now for 10, 15 years. You assume that people think like you, but they don't. Some people have bizarre expectations as to what they think is going to happen at the end of the consultation. So we found out in the section 1, we found out about the psychosocial and that impact on their life. We've done their ideas, concerns, and expectations. And now you can go mad with your disease bit. So this is just completing your history, and then looking at excluding serious illness. And if you struggle with the excluding serious illness side of life, then you need to read a book like something like Symptom Sorter or something similar, because each symptom has a series of red flags, doesn't it? So let's say, for example, back pain, you know, bowel and bladder problems, you know, tingling or numbness, loss of power, you know, each symptom, headache, you know, if you've got a headache, then the red flag ones are all about space-occupying lesions or meningitis, and they say space-occupying lesions would be, you know, things like the headache getting worse when you're lying flat, the headache getting worse when you're sneezing or coughing, and you know, it's not a headache that's worse at the end of the day, is it? And lots of other things like that. So you've now done section 1, you've done psychosocial ideas, concerns, and expectations, and you've done excluding serious illness. You should be now in the middle of the consultation. So you're moving on to section 2, and section 2 is the examination. And you should be moving on at about 5 minutes. And so when you're learning to consult for the CSA, you need to get to a 10-minute consultation on a regular basis. If your trainer says to you 12 minutes is absolutely fine, it isn't fine, because the clock in your head that's telling you where you are is getting you to the end of the consultation at 12 minutes. So I would suggest you don't write anything on the computer, but you aim to get to 10 minutes for at least a month or 2 before you sit the exam. So you've done section 1, you've gone on to examination, and you know you're not going to find any clinical findings because these people are role players, and we don't have fixed clinical findings, certainly at the moment in the CSA. But that doesn't matter. What you need to do is examine with a bit of gusto, show us that you know how to examine a patient. And if you don't know the standard of examination, there's a really good e-learning module on the RCGP website. And it shows you the sort of standard that we need. It's not Houseman or SHO level. It is what a good GP would do in their surgery. And we expect you to do that examination in 1 or 2 minutes, 3 minutes, absolutely at most. The sort of things that are going to be examination cases in the CSA are likely to be musculoskeletal or a big system like an abdomen or a chest. And so you need to really practice that. So in your small groups, you need to get with your friends and practice a slick examination that you can get through quickly. So you've now done section 1 and section 2, and you're on to the explanation part. And the explanation part is you need to make a working diagnosis. And sometimes, as we've said, there isn't a diagnosis, is there? But that doesn't matter. What I want you to do is to use their ideas or use what their wife or husband was worried about in the explanation. And so you actually say to them, you came in and said you thought your headache was a brain tumor, when in fact it isn't. And so you say, I'm 99% sure that your headache isn't a brain tumor, but it is. I can understand headache is a worrying symptom. And so we're going to treat that symptom. So I want you to address that. I want you to think about the fact they've come in with some anxiety. And so what you're really saying is, I'm going to take that anxiety and I'm going to speak to you about it, as opposed to just jumping into, oh, let's get straight into the management plan, which I don't want you to do. So you're then explaining to the patient, bearing in mind what they came in the first place, bearing in mind their theory, bearing in mind what they've said that they wanted you to do. Let's say, for example, someone says, I thought I might need some antibiotics for my sore throat. Well, actually, you could say, well, we've been through it, and actually examining you, I don't think it's a bacterial infection. It certainly doesn't look like it. So you're making a working diagnosis, or you're just using their anxieties. You're then going to agree. You're then going to discuss what the options are in light of their expectations. And then you're going to talk about what action you're going to take. And then you're going to say, and this is what we're going to do. We're going to follow you up. It might be an acute case. I'm going to send you to hospital. It might be somebody who's got a stable condition at the moment that you're going to put some caveats. You know, you've got a headache, which doesn't show me any sinister features at the moment. But if you get some sinister features, I want you to come back. Otherwise, perhaps we could try a management plan and see you in 2 or 3 weeks type thing. Okay, so you've now got your 3 sections. You need to be aware of how to go through those sections. You don't want to use my words. You want to be able to develop those sections into a series of questions that you find easy to ask and easy to remember. Don't forget it's a one-way street and you need to practice it. And the beauty about postgraduate exams in general practice is we're examining what you need to do every day. If you can consult well in 10 minutes, you will actually enjoy being a GP. If you'll still get to the end of your training and you're diseased focused, even if you get through the exam, you're going to hate being a GP. So you genuinely need to get on top of this, managing and looking after people with illness behavior. And so how does it help you score well? Because I haven't really talked about the scoring system. We did do another video, but we didn't record it. We'll come back and talk about all of that another time perhaps. But you're scored in data gathering, which is your history taking and examination. We talked about you get examined on interpersonal skills and you get examined on clinical management. So hopefully you'll see my 3 sections are divided up so that you score maximum, you get the maximum score in each of those sections. So don't forget, get your own structure. We have a structure, obviously, on 14 Fish. You're very, very welcome. Register on the website. Come and have a look what we do. We'll put it up as a PDF so that you can see it. Have a look at the structure that we use. You're very, very welcome to use it. Come and have a look at some of the things that we're doing on the package. So dividing the consultation into 3 sections really helps you score in each domain, and it maximizes your score. And it really doesn't matter who you are. Lots of people think, I'll never pass the CSA. You know, one of my friends has failed. It doesn't matter who you are. If you consult well, you're going to pass the CSA. And if you consult well, you're going to enjoy being a GP. And I think it probably took me 2 or 3 years of being a GP to understand about consulting. I actually consulted for a short period of time in a white coat, so I thought I was still some sort of budding interventional cardiologist. So you've got to make that transition from hospital medicine into being a GP and focusing on illness behavior. So I hope you're enjoying what you're doing in training at the moment, and I hope that preparing for the CSA hasn't become a whole massive focus for you in your life, because actually it's there for a reason. It's there to help you consult. I'm here with, I haven't introduced Phil yet, so one of my good friends from 14 Fish is here to help, and so that's Phil, and he was going to go and beat up the builders, which might have saved me a bit earlier. So I'm very happy to answer any questions that have come in. We're going to do as much as we can to help you get through the CSA, and so if there's something particularly you need or you think you need, do get in touch.
So we had a couple of questions from before we started the video.
First one's from Hannah. She says, I've heard there's a 14th case. Can you tell us anything about that?
Okay, so this is quite important. So there's no doubt in the CSA, the more cases that we test you on, the more reliable we can make the exam. And so we've been trialing over the last, well, since May actually, since May 2017, we've been trialing a 14th case, which is a written case. And the written case is predominantly around complex prescribing decisions. So at the moment, the 14th case is still piloted. It may be piloted through next year, but there are no immediate plans for that case to be counted. So don't worry about a 14 case. It's likely to be about a complex prescribing decision, possibly looking at, how you might, an elderly patient registered on your list and they've got 20 bits of medication. How would you decide which ones to continue? So it might be something like that. And it's likely to be structured. So there's likely to be 3 or 4 sections. But don't worry about the 14th case. It doesn't count towards your final score.
Okay, and then a similar question, I guess, about the cases. How many do you have to pass in order to pass the exam?
Okay, so when we first started the exam, we were doing 12 cases and you had to pass 8 cases to pass the exam. And actually, because some cases are harder than others, we've stopped using that method. And so we use a different mathematical model to do it. It's called the borderline group method. It's a little bit complicated, but it's accepted throughout the whole of the world as a very, very, as a gold standard way of marking exams. So there isn't a specific number needed to pass, and that's why the pass mark changes on each day through each palette. So if you get a harder palette, so if the 13 cases, that's what we call a palette, if the 13 cases are harder, the pass mark is likely to be lower towards 70, and if your cases are a bit easier, it might be a bit higher, say 73, 74. So it's not now down to the number of cases that you need to pass.
Okay, and then
and the other thing is, if you get a really tough case, don't panic, because you can make a real mess of a few cases, and there's no doubt. I've seen people in the exam, and they think they've done really badly in a case, and sometimes they've completely misjudged it, but they've done very badly or they think they've done badly in a case, and then they get really upset, and then it affects the next case. Just like in general practice, if you have a bad case, you've just got to leave it. We all have a blind spot in medicine. So if you have a bad case, don't panic. Don't make it go on to the next one.
Okay, and we've got one more question. Do feel free in the comments ask any questions that you've got. The last question that I've got here is from someone wanting to know if all the examiners are practicing UK GPs.
Yeah, so that's really important, because you don't want to be examined by non-GPs. So all of the cases are set by the case management group, and you have to be a practicing GP to be part of that. And all of the live examiners are live GPs. They have to be doing at least 2 sessions a week in general practice, and that's only fair. It's got to be realistic. It's got to be what you do every day. We don't want to examine you on complex neurological problems. There are people on the exam who aren't GPs, but they're there in an advisory capacity. So we've got psychometricians and mathematicians and psychologists, and we've got lay people on the exam. We've got role player advisors, but they're not involved in the assessment. You will only be assessed at the level of UK general practice.
And I can see we've had a couple of do you want to start with that one?
Yeah, do you want to read that?
Sorry, I'm just going to squeeze through.
That's okay.
So we've got a question. So can you make a candidate score in 1 or 2 domains in one case?
Yeah, so all of this is a really, so that's a really good question. So some cases, it might feel as if it's difficult to score in data gathering. For example, if somebody came in for the result of a blood test, it's quite easy to go straight into your clinical management, interpersonal skills. It's really important to realize it doesn't matter what case you're doing, it's marked in the 3 domains: data gathering, interpersonal skills, and clinical management. So if you get somebody who's coming in for some results, don't forget that you haven't seen them before, and it's perfectly reasonable to say, let's go back a little bit, give me a little bit of your history, because it's important that you score in data gathering. If you only score in 2 domains, you're only scoring out of 6 when your maximum score is 9. So each domain is out of 3. So 3 domains in each case is 9, maximum score of 117. And some people have rattled in somewhere in the order of 115. So there's been some really great scores out there. But yes, that's a really good point. Make sure that you score in each domain.
Liv Henry asks, would you recommend the best time to sit CSA is in your ST3 year?
There's no doubt that it is an exam in general practice. There's no doubt that the later you sit your exam and your training, the better the more likely you are to pass. I would say you've got to look on your experience, but also you've got to think to yourself, when is your life a convenient time? You know, if you've got small children, if your partner works away, you know, if your life's busy for one reason or another. You know, we're all grown-ups now. It's not like when you're an undergraduate and you're living with a group of students. And actually, if you put your mind to it, you've got plenty of time to study. The best time to sit it is when you're ready and when you've got time to study. And you've got to remember that the CSA is about getting experience as a consultant, and so the later in ST3, the more likely you are to get experience as a consultant. But you must keep up with your clinical guidance and your clinical knowledge. So, you know, a lot of people sit the AKT in ST2 and then the CSA in ST3. That's fine, but you've got to maintain the sort of AKT level of knowledge to help you with the exam. So sit it when you're ready. The later, the better. You know, don't forget your clinical knowledge.
And lastly, we've just got Ranjan Das just saying best wishes from someone who was on your course a long while ago, and he's now a GP trainer himself. Thanks for the top tips.
Yeah, but I'm delighted that you're there. I'm very sad to say that one of my trainees is now one of my partners and an examiner, and so that's making me feel really, really old. But we've had some brilliant feedback. The CSA package has only been around now for a few weeks, and we've already had a number of people pass as a result of it. I had a fantastic text last night from someone who's really struggled with the exam, and it was just that little thing that, you know, they were really good doctors, nice communicators, but they just hadn't made that transition from disease-focused medicine into looking at illness behaviour. So it's really good to hear from you, and I hope you're really well.
Mary has just asked, how long would you recommend people revise for?
What you need to be able to do is to have an acceptable standard of management in the big topics in general practice. You know, you may in the exam get one thing which is something complex, but it's likely to be diabetes, you know, musculoskeletal, carpal tunnel syndrome, frozen shoulder. You know, it's likely to be simple stuff. But, you know, diabetes management and things like that is changing all the time. It's quite, in my practice, you know, our chronic disease management nurses are mainly looking after asthma and diabetes and COPD. So, you know, I really have to sort of brush up on that before the exam. And certainly, you know, I've done most of the modules in the library, in the clinical updates for the AKT and CSA. And actually, you know, it takes me a good week or two to prepare for each clinical topic. And so, you know, you probably need to have a good 3 months of looking at the library modules, or whichever way you're learning, to make sure that you're really tight with your management. It also makes you feel more confident.
Excellent. And Roma has just asked, how can we score better in interpersonal skills domain?
Okay, so interpersonal skills. So I talked about the 3 sections, and in the 3 sections, there are things that make you score. So asking about psychosocial right at the beginning. I mean, giving of yourself. I think one of the key tips I'll probably say in the CSA is put yourself into the mind that these are real patients. Don't get into role playing. A lot of the candidates start role playing, and really that doesn't help. So be as yourself. I've recently had a registrar that struggled with the exam, and they were out in reception making the receptionist coffee and smiling and laughing, and they then went into me watching them consult, and they became really quite robotic. So give of yourself in the exam. Ask the questions at the beginning, your psychosocial, making sure that you listen to the patient. And then if you're using all their explanation in the end, as I said, in your management, that will make you score really well. So the technique of dividing into 3 stages, I think, is really important.
Okay, and another question. Someone asking, if you say the name of a medication but without a dose, would you still get the marks for that?
Yeah, this is a good question. So are we marking your prescribing? There is a little bit of marking of prescribing, but it's usually to do with controlled drugs. And so if you said, you know, you've got a chest infection, I'm going to give you some antibiotics, the role player might say, you know, if we want to know, we might have asked the role player to say, what are you going to give me and how often do I take it? But it's unlikely. Don't worry too much about writing prescriptions in the first instance. So if you go, well, I was going to give you amoxicillin 500 milligrams 3 times a day for a week, and the role player accepts that, that's fine. But if the role player says to you, what I'd really like you to do, doctor, is write a prescription, they're giving you a cue that we want to see it. And that probably is going to be in a controlled drug. So if they keep saying, you know, I'd like you to write a prescription, doctor, and you keep saying, well, if you go to reception, it'll be printed out of the pharmacy, and they go, no, I really would like you to write a prescription. Write a prescription. The role player is trying to help you. But really, in general practice, dangerous prescriptions are the ones where dose is really important, are the ones that are likely to be marked. But that's going to be rare. Maybe one of your cases out of 13, but maybe even none. But if the role player asks you, get on and do it. If they're shouting at you for the 3rd time to write a prescription, then that's a cue.
Great. Okay. Well, that's the last question. If anyone's got any others, now's your last chance to comment. We'll give it a few seconds. Mark, do you want to let people know we'll put this on our Facebook page and share it with any other trainees that they think might find it useful.
And you know what? A couple of weeks ago, we did an overview of the CSA, talking about the mechanics of it, and we'll probably do that again. To be honest, it's nothing that's not covered on the website. It was just more a talk through. But if people want more of this sort of thing and would like any specific details, then we'll absolutely do our best to do so.
And we just had another couple of questions. This is quite specific. Would a candidate need to inform the Royal College if they were heavily pregnant at the time of the CSA?
I think if it's going to affect your performance, I think that's probably wise. It's quite commonplace for us to have heavily pregnant candidates, and we are sort of prepared for that. So yeah, I would definitely warn someone. And the exam is run by GPs, and so if something happens on the day, we've certainly had women who are at term or even term plus. If something happens, we're not going to sort of force you to come in and do the CSA while you're labouring. We'll give you a free go at a later date. So just keep us informed. So let us know. And that's the same with any other disability. So a disability that's likely to affect your performance, people fall over skiing and hurt themselves or do things. And equally, people have a long-term disability that, with deafness or whatever. And so do let us know, because we'll do our best to help and make the exam as fair as possible.
And a follow-up to the question about prescribing, do you have to write the full patient details on the prescription?
Yeah, if it was a controlled drug, the patient's details will be on the notes. And on a controlled drug, we would, because that's part of it, we would want you to do the prescription as fully as possible. For pretty much everything else, it's not so important. So, it might be important perhaps for an anti-epileptic drug, with dosage and so on. But for things like antibiotics and painkillers and things like that, then it's probably best to vocalize it. And if the patient doesn't cue you into writing it, then the examiner will mark you on and you vocalizing, what the drug was. So don't get too worried about writing out, prescriptions and sick notes and things like that. Okay,
and Chisholm's just asked, is it possible for someone to score 0 in 2 or 3 domains on the same case? Someone's told her that they got 1 out of 9, which seems very, very low.
Yeah, so each domain, there are 4 potential scores, which is 0, 1, 2 or 3. And so you could actually score 0 in all domains and score 0 for the case. It would probably mean, I've seen it before, and this is possibly an important point. Each day, the 13 cases are different. They're computer generated, but then one of the examiners needs to look through them to make sure that it's a sensible mix of cases. And the palette, like a sort of recipe, has an equal number of, a physical examination case, an emotionally challenged case, a mental health case, an elderly person case, someone with a long-term condition. So, so sometimes what happens is that people talk to their friends, and then say, oh, I had a 40-year-old man who had a skinhead and he had a headache and it was a tension headache. And actually it might even be the same role player, playing a different headache the next day. So he might be playing the brain tumor the next day. And so, you sometimes see candidates see somebody and they've obviously been talking to their friends about cases, which is really unwise. And they then sort of say, well, I noticed you've got a headache, and obviously you've been worrying about this, haven't you? And they just don't listen to the role player, and the role player's going, no, I haven't been worried about it, but my headache's worse when I lie flat and when I cough and when I strain, and I've had tingling in my right arm, and I've slurred my speech a few times, and the candidate keeps going down it's obviously a tension headache, and you're obviously a bit stressed, and maybe we could give you a bit of counselling. So you do see in some cases where people get completely the wrong end of the stick. Their whole consultation is jumbled, and as a result, then they do score. They can score 0 or even 1 in a domain. So that does happen.
Okay, I think that's the last question. If anyone's got any others, we've still got time to answer any. Like I said, please share this with any other people that taking the CSA who you think might find it useful. It'll go up on our Facebook page shortly after this.
And thank you everyone for taking the time out. I know that you've probably had a busy day at work, and it's great to see that people are sort of joining in and really trying. And we really will do our best to help you at 14 Fish. And so do keep in touch, and we'll hopefully see you soon and do our best. Okay.
Sorry, we had one more.
Oh, sorry.
One more question. We'll make this the last one. So are the patients trained not to give their ICE ideas if they are asked to early?
Yeah, so that's really important. Well, no, actually. The role players are told that if they're asked a specific question, then they must give the answer. So they aren't told to hide anything, and it doesn't matter when you're asked. It's really important. a lot of candidates ask very non-specific questions like, is there anything else you'd like to tell me? And the role player is told they have to ask you specifically. So if the question should have been, you know, is this affecting your work? Or you mentioned that you were a builder, is your back pain causing you trouble at work? That would be very different from, is this affecting you? So definitely what you've got to just be is a bit more specific. So we definitely don't tell the role players to hide anything. But if you're wondering where to ask the ICE, if you're asking the ICE right at the end of the consultation, once you've already done their management plan and stuff, you're doing it in the wrong place. You really need to get the ideas, concerns and expectation right at the beginning, because then that colours in it and it does shape the rest of the consultation. It's really important. I know it to some people, you know, they want to sort of get the examination done and then say, is there something you're worried about? I really would encourage you to not do that. Do your ICE, as I said, right at stage 1, back at the beginning, psychosocial ICE, then do your disease monitoring thing. Your hospital doctor inside you, and it takes us quite a lot to surgically remove that. It has done for me. But the hospital doctor inside you, as soon as you get a disease or a name, you want to sort of chase it down the rabbit hole, and often that ruins the consultation. So ICE and psychosocial right at the beginning, and if you ask it in an open manner, then the role player will definitely give you an answer.
Great.
So really good luck to everybody that's doing the CSA. We're in CSA exam season, so started in October and it runs through for the next 8 months. But we'll be doing lots of other stuff in the near future. So really good luck if anybody who's taking it in the next few weeks.
Okay, thanks everyone.